we looked at this, right? Do you guys remember the ladder right there? Yes?
Yes.
Good. We talked about maturation. Did we, oh yeah. Did we look at this, the urethra differences?
You touched upon it, I know
Touched
that.
about it.
Yeah,
Females,
shorter,
it's about
like-
an inch and a half.
Males is longer.
It's longer.
Fully went in depth on the urethra.
No, I know.
We touched on it.
Touched upon it. But the urethra for females, it's about an inch and a half. Males, it's more lengthy. I'll just say it that way. Okay? You're not sure what it looks like, there's the differences through a mid-sagittal slice. Just so you know, the one on the top right is the male, the one on the lower left is the female, if you're unsure. I'm not trying to be, you know, but I do want you to realize I did have some students at one point in time when I had, you know, at one school we had these models, the male and female, and they thought they were two parts of the same structure, that they should fit, you know, like one half to the other half. Don't know why. They thought they, you know, that's what they did. Okay? So I'm not trying to be humorous about it. I'm trying to be very, you know, so you guys realize that. Okay? Urinary incontinence, basically, this is a lack of control, basically. You do also have it happening because of other reasons, like infections. Anybody ever cough or laugh? Did you ever lose control when you laugh? That's what happens too. It does happen. But of course, if you have an injury or something like that, that would actually cause it to happen more frequently. Okay? Infections does it too. I will tell you that much. UTIs.
Would cause incontinence?
Incontinence, yes. Yeah. So it's just, you know, and keep in mind, it doesn't mean that you're, you know, you're starting to laugh and you lose control of the entire bladder.
Is that contributing to discharge? Like if you have an STD or other infections?
Yeah,
too? Is
yeah,
that
it does.
Incorporation.
Yeah. But keep in mind, it could be just leakage. And of course, you know, that's incontinence, so. All right, even though you don't think about that, maybe. So, but you develop your ability to control this sometime when you're very young, 2 to 3 years old. Okay? You guys remember when you were wearing diapers?
No. Can I just ask a quick side question?
Sure.
From earlier? Okay, so you said that it's, you know, urine when it could be when it's unchanged, right? At what point does that happen? Is it after the collecting ducts or like through the urethra? When it's unable to change?
Oh, you mean the gender?
No, I'm just talking about urine. Like at what point is it unable to change? I'm sorry.
I'm trying to make sure I'm understanding the full nature of the question. I'm sorry. Basically, at the collecting ducts. I mean.
At the collecting ducts, after
Yeah.
the distal convoluted tube.
Yeah. In other words, what happens? You go through the distal convoluted tubule. You go to the collecting duct. A lot of times, at that point, it doesn't change or modify. But there is a portion of the collecting duct where it can still be affected by antidiuretic hormone. So if it's affected by antidiuretic hormone, at that point, it's still filtrate. But once it gets down to, let's say, the minor calyxes, it's at the end of the collecting duct. So at that point, it's definitely urine.
After the minor.
After, in the collecting duct.
In the collecting ducts.
When it's getting closer to the minor calyx. Okay? So, you know, we're looking at it where it's almost, you know, it goes to the minor calyx, to the major calyx, and then going into the renal pelvis. So basically, you have urine at that point. Okay?
Okay.
So it's a little, it's like a lot of things.
Yeah, I didn't get
It's
a clear
that
answer on
point-
Google.
It's that point sometimes is not always clear cut. It varies a little bit. Okay, that's why we have to look at it from what we're actually examining. Okay, that's why, all right? So that's why when we're looking at it, sometimes, with some, and think about this, and I tell this to you guys because I know you looked at the pH paper. Was the nature of the paper color exact?
No.
Did you have to interpret it somewhat?
Somewhat, yes.
Okay? And this is where we also see that there is somewhat of a, an interpretation of exactly where it happens. But essentially, when we're looking at it, it's in the collecting ducts where we actually see that urine actually begins to form, or no longer just the filtrate. Okay? And do you guys want me to put the nephron back up there again?
No, not really.
Yes, no, maybe? It's just a drawing, right? At
So-
this point.
Antidiuretic hormone, is that produced by like an outside stimulus or
It's produced by the posterior pituitary.
pituitary?
The posterior, here's one of the interesting things. The posterior pituitary is actually under a positive feedback mechanism. Okay? Your anterior pituitary is all negative feedback mechanism. So negative feedback mechanisms, essentially what we see when we see negative feedback mechanisms versus positive feedback mechanisms, let's take a look at it in real general terms. You might remember it from A&P I, the first chapter. Basically, you have the mechanism comes down, and what happens is you have some sort of detector, and the detector either says, okay, we continue along, or we have a feedback. Well, negative feedback, and we should talk about this more as far as the endocrine. Basically, negative feedback, it shuts down. Production when it doesn't detect the whatever it's looking for. And then when this actually dissipates over time, then it starts up again, and then we start producing, and this is basically what happens. Positive feedback, basically what happens is it goes down, we have the detector, and if we don't find it, what happens is it produces more. It causes it higher production. It doesn't shut it down. In other words, it starts it off when it's lower than a certain point. Posterior pituitary, things like antidiuretic hormone, oxytocin, these are hormones that actually increase the level of that, and when we don't find it detected, it increases it again. In our case, we're looking at it, and if the system goes wrong, we produce more antidiuretic hormone. It causes more an effect to the sodium, which then affects the water.
Reabsorption.
Okay? So that's why it plays a role here. Okay?
When it
And-
affects the sodium, is that what would cause water retention?
Yes, and that's basically where we actually get the water retention each time. Remember, water follows the sodium. The higher the concentration of the sodium, the water migrates to it. And you guys might remember, I keep saying this, but if the sodium level is high, the concentration, remember, normally we go from a high to a low concentration. Okay? So when we're actually looking at it in that sense, what happens? Water, if you're looking at that same location, water is usually at a lower concentration at a higher concentration here. So what happens? It migrates where the sodium is. Osmosis. If you're not sure, take some salt, put it on your tongue, a good amount, And guess what? It'll actually make you thirsty. It'll draw the water. That's why gargling with salt water is used in when you have extractions from dentists. Or if you actually have a cold and you have a sore throat, just try to reduce the swelling. Okay? Same idea. Okay?
I have a question about the urinary
Sure.
incontinence. I know that's common for women who have children. Is that because of damage to the sphincter, or like, is that actually the bladder itself? Or is it-
At what stage though? Of their
Normally people who have had children.
Okay,
Normally have
postpartum.
Postpartum, normally
Okay.
have problems with incontinence.
A lot of times that may be because of damage due to the, delivery. And when I say that, I want to be very careful about this because sometimes it may be damaged during the delivery itself. It may also be related to, sometimes it may have some, because there may have been an episiotomy that may have actually been a little bit more extended than expected. And it may have actually, caused some damage that way. So there's a, combination of those that could happen.
So it's not like damage.
Yeah. I mean, did I tell you guys my wife cut herself a couple months ago? Or a month ago, or whatever it was, a month and a half ago, 2 months ago? She was cutting avocado for our son because he likes avocado. She cut her finger right here, between the fingers, down to the bone. And it wasn't bleeding. And then bled later on. She has nerve damage because of it.
It's pretty common.
Avocado
film
cuts are common.
Yeah, it's pretty.
Bagel cuts are common. And then you have people that stick their knives up in the dishwasher. But damage to nerves can be, irreversible. I mean, right now she has some numbness, but she's starting, she's beginning to feel something there. When she went to the hand surgeon, they said, well, it may do something, it may make it worse, surgery. So, she decided she'll live with it, rather than taking the chance. Having some function to it and having something is better than nothing.
What causes that irreparable damage when there's nerve severs?
Well, think of it this way. You cut the nerve, you damage the receptor, it may be permanent. Because a lot of nerves, they're not repairable. Okay? They don't repair themselves. That's why. But we'll talk about that when we get to the nervous tissue. Not today. Okay? So anyway, does that cover? So one of the things that we also see is we have to look at, and I talked about this already, so I'm not going to talk about it, where we actually get rid of waste from other organ systems. Sweat, lungs, feces, that's all that says right there. Development, basically it develops from the mesoderm. This is one of those things that I talked to, somebody asked me this, and I'll reiterate this real quickly so you guys will understand this. When we actually look at early development, we actually get the development as an embryo, early embryo stage. And what happens is you develop a ball of cells, and then you develop what's called a blastocyst, which actually is a hollow ball of cells, and then it starts invaginating. Invagination is where it indents. What happens is when it indents, it actually develops 3 types of tissue, okay? The one that indents or progresses in, that becomes the endoderm. Endoderm actually develops later on to develop into, let's say, the digestive tract, urinary tract, the respiratory tract, all those different things that comes from the outside. And inside.
inside. The outermost portion becomes the ectoderm. Ectoderm actually creates things like your integumentary system, the enamel on your teeth, so the portions of your eye, okay? So that all develops as the ectoderm. And the portion in between becomes the mesoderm. And the mesoderm basically, one of the things that we see is it develops into things like your the cardiovascular system, where you have your blood vessels, your heart, your muscles, your bones, all those connective tissue areas where it actually connects the outer with the innermost. Well, later on, what happens is that mesoderm, a lot of times with the urinary system, it actually causes the development where it actually connects, where it actually filters with the blood. That's basically why, okay? And I'm not gonna worry you guys about the different portions of the kidney. It's not going to be as concerning, but you can take a look at pictures of that, okay? But the development is very critical because basically you have to have the development of the urinary system where it actually functions. As you guys might recall, you're born with the same number of nephrons that you have today. Of course, some of them may fail because of damage. But that's, so that actually causes over time a decline in the effectiveness. Usually it starts to occur around the age of 40 in some people. And of course, it all depends on what you do to your body. It's like anything else. You consume things that are going to cause more damage to it, of course, it's going to decline much quicker than if you don't take those types of things, okay? But that's, something to be aware of. And you'll notice you do lower your blood flow, which also helps as far as causing less functionality. Your kidneys shrink in size, and you have more susceptibility to other problems because of the aging process, such as kidney stones, which is what canal-Cooley is. That's kidney stones, okay? And some men will also have prostate cancer, which will also affect the ability to actually urinate. But it can be treated. Some of the disorders we talked about, kidney stones. So that's basically where we get kidney stones that actually create blockages that actually migrate down and could cause problems in that sense. But we use different methods. We use sonic waves. We use endoscopic devices to break up the stones sometimes. It varies depending on the location of the stone, the size of the stone, and things like that. Your UTIs are a big thing. Like I said, females are more susceptible because of the length of the urethra, but basically it migrates from the outside inward. Could be a bacterial infection, and that's the most common. Most common UTI, E. coli. Where does it come from? Rectum, yes. Because somebody either did not have a good wiping technique, they wipe back to front, or hygiene. Hygiene effects. Now keep in mind, you guys don't think about this, but sometimes there have been issues with people that, you guys know what, I'm thinking of it right now. It's basically staff, trying to think of it. Anyway, doesn't matter. Toxic shock syndrome.
Like a staph infection?
Yeah, staph infection. You guys know what toxic shock syndrome is? At one point in time, it was actually discovered, and a lot of times females were most susceptible because of, well, it was related to hygiene, of not,
different things. But the real bottom line is because, you know, there's moisture and the moisture wasn't taken care of in a timely fashion. And that built up over time to create bacterial growth, and the bacterial growth actually had some toxins. That's basically it. Do males get it? Yes, they do. And if they, you know, you figure if they actually, you know, perspire a lot, exercise a lot, and don't wash and clean and dry it off, what's going to happen? You have more growth, okay? Because you think about any infection. Infection's like three things: warm, dark, and moist. In your groin area, it's dark, it's warm, and it's moist. So you've got all three conditions satisfied for these microbes to grow and survive. You can have them named all different kinds of things like urethritis, cystitis, uretitis, depending on the location it is in the urinary system. You also can have pyelonephritis, which is where the kidneys become infected, typically outside in. Okay. Glomerular disease basically is inflammation of the glomeruli. You guys might remember I also talked about when you actually see nitrogen, when you see amino acids or proteins actually leaching out from the urine. A lot of times that's actually related to identifying problems with the glomerulus. In this case, some of the glomerular infections may be related to a strep infection. Chronic renal failure, this is where the disease progresses and it finally fails eventually. And you have polycystitis, which is another disease of the urinary system. Any questions about the urinary system before we go on to the next portion? Going once, going twice. Okay. So let's talk about the next one. What are we really looking at? We're looking at fluid, electrolytes, and acid-based balance. So when we're actually looking at it, one of the things that we have to look at is how do we actually look at the fluids first? So we're going to look at fluids first, and then we'll talk about pH balance, and we'll also talk about electrolytes. Okay? So one of the big problems with this is you guys drink fluids, right? Yes? Okay. Today was nice and warm. Did you drink more or the same or less than usual? You drank less? Oh my God, really? Check your pH.
My body shuts down when it's warm.
Really?
Yeah.
Okay. See, I'll say it this way, it depends on the individual too. But think about this, when it's usually warmer, you usually perspire. When you perspire more, you're losing fluids. Okay? We talked about different ways of losing fluids, but we look at what's the total volume, how is it distributed. So we're going to look at it where it is located in the body, whether it's in the cells, surrounding the cells, or in other fluids. Okay? So I want you to realize. And so that actually does affect the electrolytes and the pH. Because I want you to realize, just like I drew over there with the sodium, you have the water, the solvent, which is the higher concentration thing, because you expect your body has 70% water, approximately, right? So when you get lower than that, you dehydrate. So if it gets down to 69, 68% water, you're dehydrated. But if it gets higher, you can also have problems also. So I want you to realize that. But what happens? You also get what's called the solute. And the solute, which is what they're talking about there, is basically what's in the fluid. That could be sodium, it could be potassium, it could be anything else. It could be sugar. And we look at this, the mechanisms of how we actually control maintaining it. In other words, having that steady occurrence of what your fluid balance is. Now, if you get where your water levels are dropping for whatever reason, because of exercise or perspiring or whatever's going on, diarrhea, you know, you got diarrhea and you're losing those fluids, your body's going to try to compensate. But sometimes it's not able to, which is what that chart is showing on the far right. So if you're not able to actually control it, let's say you got injured. What happened? You were doing some gardening and you had a chainsaw and you cut off your leg and you're bleeding like crazy. You'd have extreme blood loss. Or you did this in Mexico and drank water and you're also having severe diarrhea, dysentery. We talked about that in the past. Okay, so that's why I mentioned it. So you're having this leg that's off, you got sunburn, 2nd degree burned from the sun, and you have severe diarrhea simultaneously. You're gonna have extreme water loss. But what's also happening is you're losing electrolytes, sodium specifically. If you reduce your sodium levels in your blood, you'll have hyponatremia. That's going to cause your cells to actually get affected by the water. The water is going to actually change its location. If it's actually not able to get back into control, you'll end up with water intoxication where the cells will swell and you'll go into a coma and die. Nice and simple, right? Not that we want you to, but you know, keep in mind, this is if it becomes out of control, okay? And I want you to realize it is very serious. It does affect your body very much so. So where are we looking at where the water is? Now, you'll notice on this chart, you have a male and a female. Female has 45% solids, male has 40% solids, and the rest is fluids. And I want you to realize, these are based upon volumes. Okay? We're not talking about so I want you to realize that. Now, if you look at it, you break it down into what's called intracellular fluids, extracellular fluids, and the extracellular fluids will include interstitial fluid and plasma. So what are we really looking at? Extracellular is around the cells, intracellular is within the cells. So your cells will contain 2/3 of the water. Why is that done that way? Because basically, to have the cells work, to have their normal metabolism, they need a certain amount of water to actually allow functionality. Okay? You guys know what happens when your skin dries out? It becomes less functional. Okay? That's basically what's happening. Your plasma and your surrounding fluids around the cells are what's left. And you'll notice basically 80% of the extracellular fluids are basically your intracellular fluids. 20% of your extracellular fluids, what's outside the cell, is actually plasma. So, and I want you to think about this. Look at it as having barriers between, membranes in between. So you have the membrane of the cell dividing up where the intracellular fluid is in comparison to the extracellular fluids. Okay? So this is a really simple way of looking at it. And remember, electrolytes affect what goes across the membrane.
You have a higher concentration of a certain electrolyte, guess what? It's gonna wanna migrate to the other side. But water is always going, because water concentration typically is higher on the lower concentration solute side. Okay? So I want you to realize that. So when we're looking at it, and keep in mind, this is with lean individuals, okay? So I want you to realize that, you know, we all, depending on our body shape, it does have an effect. Now, we can actually do bioimpedance tests. Once it's bioimpedance test, we put electrodes on you. Ankles, wrists, and we plug in the information about you, like your height, your weight, your gender, your age, and we can calculate, because of the impedance, the electrical current. It's not a big electrical current, so it's not going to harm you, but it's that difference where we actually get resistance, which actually we can identify how much fat you are percentage-wise through a calculation, or how much water you have. So if you're lean, there's more water. If you're more fatter or more obese or have more fat content, you're going to have more resistance. Okay? So that's all that's really saying. So basically, we talked about that. And remember, what are we talking about? Extracellular fluids? We are looking at lymph. We're looking at things like cerebral spinal fluid, which we'll talk about soon. Things like that. Does that make sense? What type of fluids we're talking about? But the membranes are what controls or actually partitions off the differences between intracellular, extracellular, between extracellular fluids and, let's say, plasma. Okay? So different walls will actually divide it up. But most of the time it's relatively stable based upon what you're doing. Because of homeostasis, because your fluids are being, you're taking in certain fluids and things like that. So we try to actually maintain those balances based on what's going on. Osmosis is what will actually control some of the movements. But keep in mind, sodium actually affects it. And all the electrolytes affect. Sugars will affect it. Let me ask this question. When you ate your 5-pound bag of Hershey chocolates in one sitting, or even less than that, if you go out today and you drink something that's sweet, do you feel more satisfied, or do you still feel thirsty?
Thirsty.
And the bottom line is that thirst is because that sugar actually has an effect, just like electrolytes. That's one of the reasons why, if you actually know some places that you may go to, they will serve you water, especially during the summer, where they actually put slices of different fruit in there, especially citrus fruits, because the citrus fruits will actually add in hydrogen ions, and they will also give you electrolytes. Okay? Years ago, they used to have salt tablets for some people because it was just, they didn't think about those things. Okay. When you gain or lose, okay, you guys ever gain weight or lose weight? Okay? A lot of it depends on also the water. Okay? So, this is one of those things that we can look at. So, if you're looking at this, notice how you gain water. You gain it from metabolic occurrences, where you break down large molecules into smaller. You get it from ingesting foods. And then you also ingest liquids. How much do you guys drink?
Like on an average day?
On an average day?
Maybe 8 to 12 cups of water.
Do you honestly do that? I'm asking. I'm just asking
Yeah.
the question. You know, I usually only drink coffee, so I get it from different means.
I have a very physical job, and
Okay.
I do work out regularly, so usually between 8 and 12 cups of
Okay,
water.
so that's fine, but not everybody does, is what I'm trying to say. And that's why I asked you. You don't. Okay? So it varies from individual to individual too. I want you to realize that. But those are where we normally gain the water. Where do you get rid of it? If you notice, GI tract, you lose 100 milliliters. Lungs, because of, you breathe out and it actually gets moisture in it. Skin, because of perspiration. And the big one, kidneys. Now, like I said, when we actually look at kidney function, when we're looking at trying to figure out what's going on with a person when they're not having functionality, we look at intake and we look at output. That's why we put a Foley on them, and we can check exactly how much fluids they urinated on a daily basis. Okay? And it should be approximately the same, equal amounts. You'll notice in hospitals, what they do is they also force fluids. Part of the reason they force fluids is because there's not enough activity, not enough movement. That movement actually helps bowel activities. And a lot of times it can actually cause them to become more constipated. And it's easier to force the fluids to a patient that's in bed. That's why they have the pitcher right next to the bed, in addition to what they normally get with their meals. And if you request it in the hospital, if you're staying there, you want to drink some more, they'll order up some things for you, depending on, your conditions, of course, what they can give you and what's available.
They have different percentages too.
What's that?
Different percentages for the saline. They give
Yeah.
4%, 9% for the concentration.
Yeah, they do. So, it does happen that way, okay? So, like I said, one of the things that we also look at is dehydration. You dehydrate. Anybody ever dehydrate?
Yep,
Yeah,
severely.
I have to. I told you my story about it, right?
You what?
My story. When
About
I did-
dehydration? No, I don't think so.
Yeah, I did. First week. When I had to be taken to the hospital after having
Oh
diarrhea all
yeah,
night.
that's right. You're diagnosed.
See, you forgot.
It's
Okay, but basically you do have symptoms of dehydration right away. Your lips become dry, your skin becomes dry, your eyes become itchy and dry. You have a desire for thirst, okay? Your blood pressure can also decrease because basically
Your
blood pressure
drops.
is affected by the volume of fluid,
become flushed.
okay? And of course, you try to compensate by angiotensin II and things like that to the kidney, but it also stimulates the thirst center to say, you're thirsty, you're dehydrated, and hopefully you drink something, okay? And it brings it back to normal. That's basically what it says. So when we're looking at it, like I said, metabolic, water volume, is basically related to what you're doing aerobically, what you're breaking down. Those large molecules into smaller. You have to add water, and a lot of times that depends how much you're breaking up or how much you need to build. Okay? But basically, drinking will actually reverse the dehydration. If you're having,
Unless you're like severe, then it could cause shock.
yeah, of course, that's things don't get corrected within that relatively short time. Okay, so
So what point are you looking at when it can shock you with like the intake of fluids?
well, we're looking at it maybe
Like, where does it become like irreversible unless there's like medical intervention?
Basically, when you start to actually get past the normal dehydration point, where it's actually causing your cells to swell. And
It
actually
actually causes
undergo,
swelling in
yes,
the cell?
they get water intoxication because the differences between the water on the outside and the inside is so, it's different. And remember, normally your cells have a good proportion of the water there. And so what happens at some point, if you're dehydrating, your water levels on the outside have declined so much that now this has more water and it affects it. Okay, so that's one. And like I said, a lot of it is also related to what's going on. A lot of it's related to how the hormones are affecting your kidneys. So antidiuretic hormone will actually affect it. Yes, Chris?
When the concentration of fluids on the outside of the cell decreases, why wouldn't that hypertonic cell release water?
Because the electrolytes are still there.
Oh, and that's what's holding it, that's what's drawing it. Okay.
Yes. So to actually, when we have water loss, you have the antidiuretic, you have the atrial natriuretic peptide, you have aldosterone, that are all involved in urine production, that are actually helpful as far as changing that situation. And like I said, we also looked at this, when we look at it, if you eliminate water, excessive water, basically what's going to happen is, or you eat salty things, this is going to have an effect. And like I said, I've been saying for this unit, sodium leads, water follows. So the water follows the sodium location. Okay? When we also look at it, when you consume more water, guess what happens? It builds up more fluid in your body, and then you excrete more water. If you have edema, you will actually have a buildup of electrolytes in the tissues, and that will then build up fluid spaces in that area. So edema does happen. And a lot of times they actually compensate by actually having some sort of, pills, and a lot of times potassium may be added in those pills to actually try to compensate. Okay? So a lot of times we affect the solute, or the particles, the electrolytes, to actually affect the water. Yes, Chris?
So what would primarily lead to like water intoxication when you ingest too much? And why would it not be expelled?
It's not and keep in mind, that's what you normally would do. When you're undergoing water intoxication, you've gotten to the point where you're dehydrated severely, but you're not able to compensate for whatever reason. Think about the patient who actually has had severe burns, 2nd and 3rd degrees on major portions of their body. They're leaking, or I won't say they're leaking out, but they're evaporating water faster than their body normally expects. So what happens is water's leaving, the sodium and the other electrolytes are staying there, and they're having an effect on the water that's left. The sodium levels are increasing and increasing outside the cell. Okay? And so what happens is the water is not able to move fast enough, and the electrolytes are not moving fast enough. And so it has this imbalance, basically. But basically what we see is, we can actually see atrium, the volumes will change. Atrial natriuretic peptide will be a factor. Angiotensin II will be a factor as far as slowing down remnant, trying to get reducing the water and the sodium reabsorption. You'll have decreases to sodium and chlorine reabsorption with aldosterone. Okay? So we're trying to actually help regulate it each time. And so what happens is the hormones, like antidiuretic hormone, is going to also get stimulated when you have thirst. That thirst is going to increase the antidiuretic hormone, which will then cause some reabsorption, that last 5% of water at the collecting dump, so that you don't actually get the levels of the water reducing as much. Remember, what is really affecting is the sodium, and the sodium is then affecting the water movement. Okay? And remember, normally, antidiuretic is not really doing a whole lot, but when you have severe dehydration, severe circumstances, second and third degree burns, internal bleeding, or external bleeding to a great level, severe diarrhea, vomiting. These are all circumstances where you're going to see changes to the fluid levels in the body. And in those circumstances, that's where we actually look at this table, what's going on. That if you're not able to compensate with the sodium levels because they've decreased, it's going to affect the water levels.
Like hypervolemic shock?
Yes. And remember, each one of these points that we see, if you're not able to readjust it and basically stabilize it at that point, it'll progress further along. And it becomes more dangerous for the patient. But a lot of times, we try to actually stabilize it at that point so that it can actually have it going back up rather than going down on this chart. Okay? Look at the example that gentleman I talked about as far as what happened with him, with his blood sugar levels. If it progressed in that direction and continued that way, we would have had a statistic on our hands at that point. But because he was able to actually have intervention where he was able to be stabilized and to start bringing him back to normal levels, it then allowed him to then recover. Any questions about fluid balance? Okay, electrolytes. Electrolytes, what's the term for electrolytes? Basically ions, charged particles. What do we actually see them doing? Well, there's 4 general occurrences. They're involved with osmosis, controls, what we just talked about for the fluid balance. They're involved with acid-base balances. They're involved with electrical. Why do I say electrical? You have a heart, it actually has an electrical current. Basically what's happening is there's a difference of the sodium levels inside and outside the membrane. It's more sodium on the outside than on the inside. So when you actually have a trigger that actually causes permeability, the sodium rushes in. That means that the positive charge moves from the outside to the inside. That's a current. It's very small, but it's still a current. That's what happens with any time you actually have muscle activity, including the heart, or brain activity.
So that's why EKGs can be done on a patient. That's also why EEGs can be done on a patient. Because you can get the electrical currents to actually understand what activity is going on with either the muscles or the neurons. That's also why with an EKG, you don't want the patient to move, you don't want them to think about too many things. You want them to be at rest. Because otherwise that may actually create other electrical events in their body. We also have something called cofactors that involve enzymes. Now, I didn't really talk about these too much, but when we get an enzyme, you guys remember enzymes? You remember talking about enzymes a little bit? Okay,
Yeah.
so we've got this enzyme, and it looks something like this. Okay? But then we actually add on things like this structure, which is organic. Let's give it another name. You recognize that one? Okay. Then we'll add on our inorganic.
Minerals. Yeah.
Mineral cofactor, which actually those two things may make that enzyme functional. Okay? If they're the right ones. This is why I mentioned sometimes we actually have these, those trace elements maybe actually being affect maybe one specific enzyme to make it functional. Without the cofactor, it's non-functional. Okay? So that's why it does have a role. Okay? And most enzymes, they work on what I'm going to call a lock and key type model. It has to be exact. Otherwise, it doesn't do the function that it's designed for. So when we're looking at electrolytes, one of the things that we also look at is how many we have. Some are going to be cations, some are anions. Cations are positively charged, anions are negatively charged. Okay? Name one cation that you have heard of recently.
Potassium? Sorry.
Okay, good. That's
Sure.
another one.
Okay.
Okay?
Which one were you referring to? Oh, the,
It's right up there.
yeah.
What is
Salt.
that?
Salt.
Sodium.
Sodium.
Okay? So, I mean, we're gonna have some that are, positively charged, some are negatively charged. But they do affect things, I'll say it that way. So the number one that we actually, and we'll look at it from each of the different solutions. So let's look at this chart. Take a look at the chart. We actually have, red is plasma, blue is intracellular, that's your extracellular fluids, and then yellow is intracellular inside the cells. So when you're looking at it, you'll notice the first one that is there is sodium for all three parts, potassium for all three parts, calcium for all three parts, magnesium for all three parts, chlorine for all three parts, monobicarbonate, phosphate, sulfate, and protein. What's the highest cation? Where would you see this outside the cell? The highest? Sodium.
The
Can you
chloride?
see that?
Yeah.
What about potassium? Where's that highest?
Intracellular?
Intracellular, inside the cell, as a difference, okay, to compensate for those levels. And you notice they're almost the same level as the sodium levels, okay, but inside the cell. And most of the time you'll see sodium actually has to have the mechanism, whereas potassium leaks out over time, okay? And you'll notice which one seems to be highest as an anion, inside or outside the cell? Outside the cell, we'll say.
Chloride?
Chlorine, yes,
Chlorine.
chlorine. And then phosphate
is highest inside the cell.
Or something.
Okay? So this table gives you a good comparison to understand which electrolytes are where at any in general. Okay, so we're going to go through each real quickly. Okay, just so you have an idea what they are and where they are. Sodium is the most abundant extracellular ion. Okay. You do take in a lot of sodium in general. How many of you add salt to your food? Yeah, I know. That's what I'm gonna say. But sodium you can actually get in food itself. If you actually eat, healthy foods, a lot of times it's in there. So one of the things you'll notice is aldosterone will increase the reabsorption of sodium. Antidiuretic basically ceases levels when they're too low, and you urinate more or otherwise. And atrial natriuretic increases sodium and therefore the water that gets excreted. If you have too much sodium, you get edema. If you lose too much sodium, you get water loss, and you can have hypovolemia, which is an abnormal level, low level of sodium. Okay, and I want you to realize, look at it from, if it's hypo, it's low. If it's hyper, it's high levels. Okay, and of course, high levels of sodium can also cause problems like hypertension and things like that. Okay, so what happens when you actually have problems with sodium? You can get renal failure. That's one of the problems you can get. You can get edema. And what can affect it? Diuretics can affect it. That will actually cause too much loss of sodium. Okay, or if you don't produce enough aldosterone, that will also cause it to be lost. Okay, so the second most highest we're going to talk about is an anion, chlorine. Chlorine is a major one in the extracellular fluids. And I want you to realize, whatever happens to sodium, chlorine you expect to follow it, because sodium chloride is a typical salt. Okay? So it actually has the same effects. So when you actually change the sodium location, you change the chlorine location. Next one, and so when we're looking at it, chlorine does have leakage channels. And like I said, everything with chlorine, it follows the sodium. But of course, we also use chlorine for hydrochloric acid and stuff. Next one, potassium. Potassium is the major intracellular cation. Like I said, it usually is an offset from the sodium. A lot of times, charge-wise, it tries to compensate for the positive charge that when sodium's not there. So that's why you'll actually see sodium and potassium are tied together when we look at the sodium-potassium pump. And basically, potassium will be secreted in the urine also by the principal cells as an offset for the sodium. Okay? So when sodium is moved, potassium is exchanged for the sodium a lot of times. Abnormal levels of potassium can cause heart problems and neuromuscular function. I think I told you guys what happened to me about a year after when I had my surgery. I was actually getting problems with muscle because of potassium. Potassium, one of the things you'll notice also is potassium is one of those things that geriatrics also have problems with. But Another thing what you also see is your different hormones of your adrenal glands will also be requiring potassium or controlling it, like the mineralocorticoids. Okay? And a lot of times potassium also affects the hydrogen ions. Let's talk about bicarbonate ion. The bicarbonate ion is also very high in plasma, blood plasma. It is an electrolyte. It's involved in the electrolyte balance, so it does have an effect of the acid-base balance. Do you remember I mentioned that what happens is you take water and combine it with carbon dioxide, it makes the bicarbonate, and then it loses the hydrogen ion and the bicarbonate ion, or the monocarbonate ion. So that's basically what you're seeing happening. So it actually can have decreases or increases to hydrogen ions based upon the carbon dioxide levels that are in your body. So this is where respiratory effects directly to this ion. Okay?
What did you say directly against that?
Respiratory. So when you're breathing or not breathing, it has an effect. Anybody have children that are small or had children that were small? A lot of times they get into a dispute with you and they'll say, I'm gonna hold my breath until, and basically what happens is, if you think about it, they can hold their breath until, and then basically what will happen is they'll, if anything, they'll pass out and they'll start breathing again. So that until is not really, going to really matter. But basically what happens is it does get affected if you have increased carbon dioxide levels or decreased carbon dioxide levels. So respiratory problems really do affect it. Next ion, calcium. Calcium is one that's abundant. It is mostly extracellular. It builds bones, it builds teeth. It also is involved in clotting mechanisms in the blood. It's involved in muscle activity, muscle tone, because you need calcium to actually affect the contraction of muscles. It also affects neurons as far as having their normal function to create stimuli. So those are things that we do have. You can increase it by absorption in the intestinal tract, but you can also get rid of it through urinary. Magnesium, primarily in intracellular. This is involved in enzymes, especially with breaking down carbohydrates. It's also needed for the sodium pump. It does play a role with neurons and the central nervous system. It has an effect as far as the heart function. And it's affected by the parathyroid and the hormone, okay? Phosphate, PO4. Phosphate, a lot of times, also plays a role with your bones and your teeth, because basically calcium phosphate is known as the mineral apatite, which is basically that mineral deposit that creates the hardened structures within your bones, in the lamellae of the bones. Okay? It does act in the buffering system. You might remember I mentioned that there was a phosphate buffer. And so this is where we actually see it. It can release hydrogen ions, and it can accept hydrogen ions. So that's how it can actually play as a buffer, by exchanging the hydrogen ions. You do actually have it reabsorbed from the bone if you need it. The kidneys will also have it excreted, and your intestinal tract will also increase the levels of it by absorbing it. By the way, do you guys know how calcium generally gets into your body? What you consume to get calcium?
Dairy?
Meat, dairy, good, okay. How about calcium supplements? Do you know how that comes about? Generally? Yes or no? What's that? Marie, did you say? No, okay, I thought you said, okay. When they, and this is a very important to understand conceptually, sometimes a lot of products, they get calcium, but you have to be careful if it's soluble or insoluble calcium. Okay, soluble means it can dissolve in fluids. Insoluble means it doesn't. Well, unfortunately, a lot of calcium supplements, they ground up shells from oysters, and they actually encapsulate it as a supplement.
Insoluble?
Insoluble.
Yeah.
Okay, that's why I wanted to let you guys know, so that if you have patience, you'll have an understanding. Okay. All right, so.
So what is the major source for like soluble calcium that we do get?
Soluble calcium, you have to look at it if it's actually in the food sources. Okay, where you get food sources that have it, dairy, a lot of times. That's where it's soluble. Okay. Unfortunately, for lactose intolerant individuals, it then has an effect. So, but that's the major source.
Is dairy. What do you know of any like supplementals or substitutes that would give us, like a recommended calcium that is soluble?
Sometimes I would actually look at it if it is for calcium levels. I mean, you can actually look at possibly. Here's an interesting thought, and I bet you none of you would even try it. Ground up egg shells.
Yeah. I didn't think about that.
Because
That's
they
true.
were soluble in the chicken before they made the shell. Interesting.
So ground eggshells, huh?
I mean, anybody eat bone marrow?
I mean, I used to, but yeah, like beef marrow, like from the
Yeah.
bone, yeah, it's
I mean,
delicious.
that may actually also have some, not a lot, but because bone marrow depends on if you're looking at red bone marrow
Or yellow bone marrow. Yeah.
yellow bone marrow. I used to have a student, she used to eat chicken bone marrow,
It's pretty good.
okay? She would not eat the chicken though.
Oh, really?
Preferences, that's all I can say. Okay. Some of the clinical aspects, your balances are really important for normal GI tract, normal urinary tract, and I want you to realize IVs are used in many different circumstances. You actually have typical physiological saline. You actually have, sometimes you actually have glucose bags. And remember, when we actually look at glucose, we look at it at the same concentration levels that the body would have. But you have all kinds of things done. So burn victims, everything else. So this is why it's so important to understand the electrolytes, because they affect the fluids. Okay. Which gets us to pH.
We talked about pH downstairs, what the range is for the blood, that you're looking at hydrogen ions. We do actually have 3 buffers, I mentioned those. Real briefly, we'll go over them a little bit more. But basically, we actually have respiratory issues that can actually change it, breathing out more so or not enough. And we also have your kidneys will actually affect the hydrogen ions, which would be more of a metabolic type of occurrence. So one of the things that we see, buffers that they're doing is they're actually controlling the pH or maintaining it so it doesn't fluctuate too much. That's the key. We have the protein buffer system, the bicarbonate buffer system, which I talked about, and the phosphate buffer system. Basically, the protein buffer system is looking at the amino acid. I kind of talked about it downstairs, where we actually look at either the carboxylic acid, which is COOH, where we actually get rid of the hydrogen, or we actually look at the amino group, which is the NH2, where we also have change. Protein buffers affect the hemoglobin a lot of times. Bicarbonate was the one where we talked about, where we make it from water and carbon dioxide, and you can actually have a change to releasing the hydrogen ions if there's excessive amounts of carbon dioxide, or it actually, if there's not enough carbon dioxide, you reduce the hydrogen ions, which means the pH elevates. Okay? Based on that. The phosphate buffer system, basically, this is where the phosphate either gains or loses hydrogen ions, which will then affect it. Okay. Now, you're breathing. You guys are breathing, right? You're breathing.
I think so.
If you when you're exhaling, you're basically getting rid of carbon dioxide. And that's actually having an effect to pH in some ways. So I want you to realize that that has an effect on the pH. So when we're looking at it, if you have, and this goes a little bit too much this way visually, but if you're actually having when you exercise, you start to breathe heavier. Why? Because you have a drop in oxygen, but you also have a drop in your blood pressure, and your blood pH changes. Okay, so that's why we try to compensate. Your kidneys can also have, when it releases hydrogen ions when you urinate, because basically urine is going to have a certain amount of hydrogen ions in it, and that will also be noticed when you have a drop in the hydrogen ions. So that's why we have to have those buffers to actually help to maintain your pH. So when we're looking at it, it does have an effect. I'm skipping over that one. Basically, we have to look at what's going on with the system. So if it goes in the lower portion of the range, below the 7.33, 7.35, this slide actually says, that's acidosis. If it goes above the 7.4, 7.45, that's alkalosis. And I want you to realize, this gives numbers. I mentioned numbers. Different facilities will have their numbers to actually have their guides for acidosis and alkalosis. Okay? So I want you to realize. But basically, alkalosis will affect it will have overexcitability to the central nervous system, as opposed to depression. So what do? We try to compensate a lot of times. If we don't, you go into a coma, you die. Okay? Basic. Simple thoughts. How do we compensate? Well, it depends on what's going on. What was the cause? What do we interpret as the cause? If it's a respiratory problem, we then affected
by those mechanisms. If it's too much carbon dioxide, we give oxygen. Okay? We can give bicarbonate. How do we give bicarbonate? Alka-Seltzer is a bicarbonate, basically. Okay? That's if we're looking at respiratory alkalosis. Okay? Respiratory acidosis, we may actually give a paper bag. Okay? If we're looking at metabolic, we look at what caused it. Is it insulin, with sugar? Is it a matter of urinary tract problems? Does the person have a problem urinating and they're not releasing hydrogen ions? Or are they urinating too much? Or what's going on? Okay, that's causing that problem. And remember, we look at those problems and try to compensate by dealing with it. Like I said, bicarbonate is typical. If we have respiratory acidosis, we try to elevate the carbon dioxide levels. We try to remove carbon dioxide to do this. Like a lot of people that have problems like emphysema and all that may actually have problems with that. Okay? We give them bicarbonate. We ventilate them with, to increase the, getting rid of the carbon dioxide by displacing it with oxygen. Respiratory alkalosis, when it's too low, they're hyperventilating, have them breathe into a bag. That may be due to medications, such as overdoses of certain medications. Okay? Could be a stroke. Okay? Renal disease. Okay? Metabolic acidosis. What do? Have them hyperventilate. We can IV them with sodium bicarbonate. And it may be because they have a problem with, they have diarrhea or something, dysfunction in the urinary. Metabolic alkalosis, this may be because they had too many diuretics, they're vomiting, they're having diarrhea, they had a GI suction, all different types of problems. And we can, we try to correct the problem as soon as possible. Bicarbonate is one of the key things that we use. When we're looking at pH imbalances, we look at what's going on. Is it throughout the whole system or not? How bad is it? How can we actually adjust it in a relatively short time? How serious is it? When we have this happening in infants, infants are more, they have higher rates of input and output. They have greater amounts of waste. I mean, anybody dealt with a baby? You might change the diapers multiple times and they're still ready to go. I'll just say it that way. Diapers, you go through a whole box of diapers and it may only take days. That's how fast they excrete. Their breathing rate is higher. Their respiratory rate is higher. All the rates are higher. So what happens is their levels are going to be also higher than an adult. If we actually look at elderly patients, they're declining. Their functions are declining. Their levels are declining. Their potassium level decrease. Because remember, potassium moves all the time out of the cells. So what happens is it doesn't always get back into those cells. So having potassium, to actually help them is really important. It affects their heart if they don't have enough potassium. Okay. They've decreased their urinary rate. They've decreased their respiratory rate. It's not always as strong as when they were time of their life. Okay? And so, that's the unit. Ready to go. Okay. See you guys tomorrow.